Thank you. First of all, I would like to thank Professor Pnecht for your kind invitation. It's really for me a pleasure to be here and present our data. I'm going to talk about EGFR targeting and radiation therapy in head and neck cancer. And there is a strong rationale of combining both modalities because, as has been said, a vast majority of head and neck cancer patients express EGFR. We know that targeting EGFR is effective in vitro and in vivo, and combining EGFR targeting with radiation chemotherapy produces enhancement effects, and also that radiation plays a major role. In my presentation, I'm going to discuss first the clinical data on combining radiation plus cetuximab. Then I'm going to look at EGFR prognostic factor, and at the end I will discuss briefly, because there is not much data, on predicting as a factor for patient selections. So, improvement of radiation efficacy by monoclonal antibodies. And what we can say that there is solid and consistent data to show that combining both modalities is an enhancement effect. The mechanism that has been postulated to select this enhancement effect are related to cycle arrest. There is a promotion of radiation induces apoptosis. There is an inhibition of radiation-induced damage repair. And also there is an enhancement of the inhibition of tumor angiogenesis. I'm not going to show you all the experimental data because of the time, but only in a xenograph you can see how even in a single doses or in a fractionation doses, combined modalities produces really these excellent results. And these excellent results prompt the development of clinical trials. First, there was a phase 1 clinical trial that was conducted at the University of Alabama. And in their design, there is the first week there is a loading dose, and in the second week start radiation with a maintaining dose. These are the 4 level doses that they plan. And the first step, they use 100 millimeters for loading and for maintenance, and then they increase with the doses. They treated 16 patients. Most of the patients were treated with conventional radiotherapy, but the last patients were treated with hyperfractionation radiotherapy. All the patients had unresectable disease. Most of the patients had oropharyngeal or hypopharyngeal tumor, stage 4. You can see the treatment was quite well tolerated. If you look at mucositis, grade 3 mucositis, is about 2/3 of the patients, about 60% of the patients. That is more or less what we could expect with radiation alone. One patient developed a grade 4 allergic reaction, and this patient was not suitable for evaluation response. Of the 12 patients treated with conventional radiotherapy, 11 achieved a complete response and 1 a partial response. And of the 3 patients treated with hyperfractionation, 2 patients achieved a complete response and 1 patient a partial response that after surgery became a complete response. These excellent results prompted the development of an international phase 3 trial that was presented. The conclusion of this trial is that cetuximab in combination with radiation is safe, tolerable, and produces promising results. These results from the development of this phase 3 trial that was conducted internationally and was presented at the ASCO in 2004 and will be published probably in a few months. In this trial, patients with locally advanced head and neck squamous cell carcinoma were randomly assigned to the conventional arm, that is radiation alone, and the experimental arm, that is the same radiation plus cetuximab. Patients were stratified according to Karnofsky score, regional status, positive versus negative, tumor stage, T1, T3 versus T4, and radiation fractionation regimes. 3 different of radiation regimes were allowed: conventional fractionation, 70 grays given in 30 fractions of 2 grays per fraction; hyperfractionation, 1.2 grays, 2 grays per day with 6-hour interval to a total dose of 72, 76 grays. And the concomitant boost technique developed by MD Anderson, 72 grays given in 6 weeks. For the experimental arm, the same radiation was given. Every center has to decide before entering the trial if they are going to treat the patient in one of these 3 schemes. And for the experimental arm, the same radiation was given, but with the addition of a loading dose the first week of 400 millimeters square meter without radiation, and started in the second week, starting radiation therapy with 250 millimeters 1 hour before radiation. Neck dissection was recommended for patients with N2, N3 disease. Patients included had a locoregional advanced stage 3 or stage 4, squamous cell carcinoma of the oropharynx, larynx, or hypopharynx with measurable disease and suitable for definitive radiotherapy. 230 patients were treated with radiation alone and 211 with radiation plus cetuximab, and as you can see, both arms were well balanced according to Karnofsky status, nodal status, T status, and fractionation regimes. The same can be said for age, gender, primary site, and stage. One quarter of the patients, 25, had a neck dissection, and 60% of the patients and 80% in the radiation alone, and 80% of the patients in the combined modality have a salvage surgery after the treatment. The treatment was really well tolerated. There were statistically differences in skin toxicity. Grade 3-4 skin toxicity for patients treated with radiation alone was 18% against 34% in patients treated with cetuximab. And this can be related to skin rash. But what is most important is that there is no differences in mucositis. 52% grade 3 mucositis. In radiation alone, 54% mucositis in the combined modality, with 4% grade 4 mucositis and 6% in the combined modality. The same can be said for dysphagia. This slide has been previously shown. Patients treated with combined modality had a statistically significant improvement in locoregional control time. Median locoregional time for patients treated with radiation alone, 19 months, and median time for locoregional control for patients in the combined modality, 36 months. And the same can be said for overall survival. Patients treated with radiation plus cetuximab had a statistically significant improvement in survival, 54 months versus 28 months. This is data on quality of life. This morning has been a discussion on quality of life. Patients have the ARTC questionnaire with the sub-analysis of head and neck. And as you can see, there were no differences in quality of life, neither in global health, nor in swallowing, feeding mucositis requiring feeding tube, or the use of narcotics. So, in summary, the addition of cetuximab to high-dose radiation in locally advanced head and neck cancer resulted in a significant improvement in locoregional control and in overall survival with a minimal additive toxicity and with comparable quality of life. So, there is a criticism to this study that the control arm is radiation alone, and we know well that meta-analyses have shown that at present the use of concomitant chemoradiotherapy improves survival in comparison with radiation alone. Yes, but the design of the trial was to show that this strategy improved outcome without improving toxicity, and this was been well shown in the trial without increasing mucositis, and concomitant chemoradiotherapy increased significantly grade 3 mucositis. So what's the next step? From my point of view, the ideal would set to conduct a randomized trial with 3 arms: concomitant chemoradiotherapy, radiotherapy plus cetuximab with hyperfractionation or concomitant boost technique, and radiochemotherapy plus cetuximab. RTOG will start a randomized trial, but unfortunately, because of the large number of patients that would be needed to conduct a trial of these 3 arms, they decided to start this randomized trial comparing radiation chemotherapy versus radiochemotherapy plus cetuximab. So, moving to the next topic, I'm going to discuss briefly the prognostic aspects of EGFR expression. And this slide has been shown. This is the work published by Ruben Grandis. This is the first data to show in patients that have had surgery, and most of them postoperative radiotherapy, that EGFR is an important prognostic factor. And in patients treated with radiation alone, this is the data from Yang that also have been shown. Patients treated in conventional fractionation regime, there is, you remember well, the 4-arm RTOG trial, and those patients treated in this arm, included in this arm with conventional fractionation regimes, they look retrospectively at EGFR expression, and as it could be said, EGFR positive patients had a statistically significant decrease in disease-free survival and overall survival. And what is very interesting is that these differences were due to differences in local control, not in distant metastasis. What else can we say about EGFR expression and radiotherapy? As you well know, one of the strategies in accelerated radiotherapy is to decrease the treatment time in order to reduce repopulation. There has been some clinical trials, for example, the CHART trial, the continuous hyperfractionated accelerated regime. In this regime, conventional fractionation was compared with this CHART scheme. Patients were treated 3 times a day, 1.5 grays, continuously, including the weekend, so in 12 consecutive days. There is a clearly reduction in the treatment time. In this trial, more than 900 patients were included. No differences were published, but when we look at EGFR expression, we see that in patients that were EGFR positive, the use of accelerated radiotherapy improved locoregional control. And this data was not seen in EGFR negative patients, so the conclusion could be said that EGFR positive patients could benefit from accelerated radiotherapy. And this data has been also reproduced by the Danish group. They had used a moderate accelerated regime. They compare 6 fractions a week versus 5 fractions a week. And the results, they show that with these moderate regimes, they improve locoregional control and disease-specific survival. And again, for patients with high expression of EGFR, there is a clear benefit of accelerated radiotherapy, but for low EGFR expression,